Imagine you're walking into an emergency room, right? And there was a patient in absolute crisis. The medical team rushes in, they draw their blood, and the lab results come back showing perfectly normal, completely non-toxic levels of their prescribed medication.
Right. So by all standard toxicological measures, the patient is totally fine.
Exactly. They look fine on paper. But the attending doctor takes one look at the paper, printing out from the ECG heart monitor, sees this very specific widening of a squiggly line, and just knows this patient could drop dead of a fatal heart rhythm in the next 60 seconds.
It is a terrifying scenario.
It really is. So, welcome to the deep dive. Today, we are looking at a class of drugs known as tricyclic antidepressants, or TCAs. You might have actually heard them referred to as, the older antidepressants.
Yeah, which makes them sound like just a historical footnote.
Right, but they are so much more than that. Our mission today is to really understand not just what they are, but how they accidentally revolutionize the entire field of psychiatry. We're going to look at the messy collateral damage they cause inside the brain and the body.
And crucially, why they are simultaneously considered this gold standard for severe depression, and yet some of the most lethal substances you could ever hand to a patient.
Okay, let's unpack this.
Well, the central paradox of TCAs is just truly staggering when you look at the pharmacology. I mean, we are talking about the very compounds that provided the first undeniable biological proof that clinical depression could be treated medically.
They completely changed the trajectory of human health.
They did, yet handing a month's supply of a TCA to a severely depressed patient is, well, it is essentially handing them a loaded weapon. The therapeutic window, which is the gap between a dose that heals and a dose that kills, is just razor thin.
And to understand how a medication could be so profoundly contradictory like that, we really have to look at the era that produced it, because nobody in a lab coat sat down in the 1950s and just said, let's reverse engineer a cure for depression.
No, absolutely not. That concept didn't even exist back then. The pharmaceutical landscape of the early 1950s was wild. It was largely driven by just accidental observations.
Like throwing spaghetti at the wall to see what sticks.
Basically, yeah. A prime example is a chemical company called Geigy, which is now part of Novartis. They were watching a competitor make an absolute fortune off this drug called chlorpromazine.
Which wasn't even for psychiatry at first, right?
Right. Chlorpromazine was initially synthesized just to be an antihistamine, to calm patients down before surgery. But psychiatrists started noticing it did something much more profound. It actually halted the hallucinations and delusions of schizophrenia.
Right.
So it became the world's first blockbuster antipsychotic.
And Geigy naturally wants a piece of that market. They want their own antipsychotic.
Exactly. So they put their chemists to work synthesizing analogs. They took the chemical structure of chlorpromazine and started making slight tweaks, just hoping to patent a rival compound. And one of these chemical cousins was given the working title G22355.
Which today we know is an increment.
Right. So they shipped this untested compound off to Roland Kuhn, who was a Swiss psychiatrist working at a hospital on Lake Constance. They wanted him to test it on his patients with schizophrenia.
And the results were an absolute disaster.
Yeah.
It did absolutely nothing for the schizophrenia.
Honestly, it was worse than nothing. Kuhn documented that in several patients with schizophrenia, G22355 actually increased their agitation. It worsened their psychosis.
Yikes.
Yeah, so by any standard metric of drug development, Geigy had a total failure on their hands. I mean, the compound should have just been thrown in the incinerator.
But Kuhn didn't throw it out. He pivoted.
He did. Kuhn was this incredibly astute clinician. His hospital ward housed patients with a really wide variety of psychiatric conditions. So he started administering this failed antipsychotic to patients suffering from profound melancholic depression.
These were patients who were essentially catatonic, right? Unable to eat or sleep or even engage with the world.
Exactly. And within a few weeks, he observed this miraculous shift. Patients were actually getting out of bed, their facial expressions returned, they were initiating conversations again.
It must have been unbelievable to witness.
It really was. Kuhn realized he hadn't found a sedative and he hadn't found a stimulant because the drug didn't make healthy people euphoric. It specifically repaired the biological deficit of clinical depression.
It makes me think of trying to invent like a chemical fire retardant, completely failing at that, and realizing you've accidentally invented rocket fuel. You discovered something unbelievably powerful, but it just requires an entirely different engine.
That is a great analogy.
Wait, so before this, the very idea of an antidepressant didn't even really exist as a medical category.
It really didn't, which is why when he took this massive discovery to the broader medical community, They basically completely ignored him.
Which is just wild to think about today.
Right. He presented his findings in 1957 at this major psychiatric congress in Zurich, and he spoke to a practically empty room. The psychiatric establishment at the time was just entirely dominated by Freudian psychoanalytic theory.
So mental illness was viewed as a psychological conflict,
Uh-huh.
rooted in childhood trauma or, subconscious drives.
Exactly. The prevailing medical dogma was that treating these profound disturbances of the soul with a simple pill was not only impossible, it was intellectually offensive to them. Geigy executives were actually furious with Kuhn because they didn't even believe a commercial market for a depression pill existed.
But the clinical results were just too undeniable to suppress forever, right?
Yeah, they couldn't ignore patients getting better. Imipramine hit the market in 1958 under the brand name Tofranil. And the historical coincidence here is just remarkable. In almost the exact same year, a completely different drug called iproniazid, which was developed to treat tuberculosis, was independently observed to elevate the mood of patients in TB sanatoriums.
And iproniazid turned out to be a monoamine oxidase inhibitor, an MAOI.
Right, so within a single year, the medical world went from having 0 chemical treatments for depression to having 2 entirely distinct classes of drugs, both discovered completely by accident.
The modern era of biological psychiatry was basically birth through clinical serendipity, not precision molecular engineering.
Exactly, and that lack of precision is exactly what defines the pharmacology of the tricyclic antidepressants.
Well, let's break down that pharmacology, starting with the name itself. Tricyclic, meaning 3 rings.
Right, originally it described the literal shape of the molecule. The chemical backbone of classic TCAs drugs like imipramine, amitriptyline, and nortriptyline consists of 3 fused rings of atoms.
Kind of like a chain.
Yeah, you typically have 2 outer benzene rings joined by a central 7-membered ring right in the middle.
But the chemical classification has basically fallen apart over the decades, hasn't it?
Oh, totally. It's purely a functional shorthand today. Pharmaceutical chemists just kept tinkering with that central ring structure to create new drugs. They developed naproteline, which has 4 rings, making it a tetracyclic.
But it acts like a TCA.
Exactly. Then they developed amoxapine, which structurally looks like an antipsychotic and actually blocks dopamine, but it still gets lumped into the TCA category too. When a physician refers to a tricyclic today, they aren't counting rings. They are referring to a very specific and very messy pharmacological signature.
So let's look at the functional part of that signature first. The actual reason these drugs pull someone out of a deep depression. I know you listening are probably familiar with the basic concept of a synapse and chemical messengers, so let's jump straight to the machinery. TCAs act as heavy-duty blockades on the reuptake transporters.
Specifically, they target the transporters for 2 critical monoamine neurotransmitters, norepinephrine and serotonin. These are known as NET and SERT.
Okay.
When a neuron fires and releases serotonin or norepinephrine into the synapse, those transporters act like vacuum cleaners. They just suck the chemicals back up to be recycled.
And TCAs jam themselves into those NET and SERT transporter proteins. The vacuums are broken.
Yes. So the neurotransmitters are left stranded in the synapse, constantly bumping into the receptors on the next neuron, which amplifies the signal.
And this specific mechanism is what birthed the famous monoamine hypothesis of depression, right?
Exactly. Because TCAs worked by boosting serotonin and norepinephrine, scientists just assumed depression must be caused by a sheer deficit of those 2 chemicals. We now know that's a massive oversimplification. I mean, depression involves neurogenesis, inflammation, complex network circuitry, but the brute force amplification of those signals by TCAs is undeniably effective for mood.
But blocking those transporters comes at a massive cost. Because the TCA molecule wasn't perfectly engineered for just the serotonin or norepinephrine transporters. It's clumsy. It's like using a sledgehammer to ring a doorbell. Sure, the bell rings, but you also smash the porch and break a window in the process.
That is a very accurate visual. They crash into entirely unrelated receptor systems. The medical term is a dirty pharmacological profile.
So let's look at the collateral damage, starting with muscarinic acetylcholine receptors. TCAs block these aggressively.
Right, which triggers an anticholinergic toxidrome. It is a widespread shutting down of the parasympathetic nervous system. It halts saliva production, leading to severely dry mouth. It paralyzes the ciliary muscle in the eye, causing blurred vision.
It affects digestion too, doesn't it?
Severely. It slows down the gastrointestinal tract, causing really bad constipation, and prevents the bladder from contracting, leading to urinary retention. In older adults, blocking acetylcholine in the brain can trigger profound confusion and delirium.
Medical students actually memorize this toxidrome with a dark rhyme, right?
Hmm.
Mad as a hatter, dry as a bone, blind as a bat, red as a beet, hot as a hare.
Yes, exactly. And that's just the first accidental lock the key opens.
What about the histamine receptors?
Well, TCAs block histamine H1 receptors centrally in the brain. This is the exact same mechanism as taking a heavy dose of Benadryl.
Oh, so intense grogginess.
Intense, groggy sedation, and it stimulates appetite, leading to significant weight gain, which is obviously distressing for a patient who is already struggling with depression.
And then there are the alpha-1 adrenergic receptors.
Right. Alpha-1 receptors are responsible for keeping your blood vessels constricted. When you stand up from a chair, those receptors squeeze the vessels in your legs to fight gravity and push blood up to your brain.
But TCAs block those receptors, so the blood vessels stay dilated.
Exactly. You stand up, the blood pools in your legs, and your blood pressure just plummets. This is called orthostatic hypotension.
For a 20-year-old, it means feeling dizzy for a second. For a 7-year-old, it means fainting, falling, and shattering a hip. Is this messy profile the exact reason SSRIs were invented later?
It is the exact reason. SSRIs were a triumph of precision engineering over the clumsy sledgehammer of the TCAs. But the side effects we just discussed, as miserable as they are really just quality of life issues. The true defining characteristic of TCAs, the reason they terrify emergency medicine doctors, is what happens when that clumsy molecule crashes into the human heart.
Which brings us back to the scenario from the intro. We need to completely separate the concept of an overdose here from modern antidepressants, because most people assume that taking a whole bottle of an antidepressant will just flood the brain with too much serotonin, causing serotonin syndrome.
And serotonin syndrome is a very serious and potentially fatal condition, but it's typically triggered by mixing multiple serotonergic drugs. In an isolated TCA overdose, serotonin syndrome is rarely the cause of death. The true lethality of a TCA is fundamentally cardiac and neurological.
So let's focus on the heart. To pump blood, the heart muscle relies on an electrical wave of depolarization, and the spark that ignites that wave is sodium.
Exactly. Every single heartbeat begins with a rapid, massive influx of sodium ions rushing into the cardiac cells through fast, voltage-gated sodium channels. This is phase 0 of the cardiac action potential.
It has to happen instantly for the heart to contract in a sharp, coordinated rhythm.
Right. And the TCA molecule acts like a physical cork in that channel. It binds directly inside the cardiac sodium channel, physically blocking the ions from rushing in, and the blockade is use-dependent.
Meaning the danger scales with the heart rate.
Precisely. The TCA molecule can only access its binding site when the sodium channel actually opens. If the heart starts beating faster, which often happens in an overdose as the body panics, the channels open more frequently.
So more doors opening means more TCA molecules can rush in and jam the channel shut.
Yes. The electrical conduction through the ventricular muscle slows down drastically.
And if the electrical signal slows down, the physical contraction becomes wide, weak, and uncoordinated.
Right, the rhythm degrades into ventricular tachycardia, where the bottom chambers of the heart are quivering too fast to pump blood, and that rapidly deteriorates into ventricular fibrillation and full cardiac arrest.
And if you combine that collapsing heart rhythm with the neurological chaos, the fact that TCAs drastically lower the seizure threshold in the brain, you get the emergency medicine nightmare.
The classic triad of TCA poisoning. ER docs call them the 3 Cs: coma, convulsions, and cardiac conduction abnormalities.
Which brings us to this brilliant 1985 Bonert and Lovejoy study published in the New England Journal of Medicine. They needed a way to predict which patients were going to seize and which ones were going to go into cardiac arrest, because waiting for a blood lab to process the toxicological screen just took way too long.
What's fascinating here is how Bonert and Lovejoy turned abstract cellular pharmacology into a 60-second bedside triage tool. They realized that because the TCAs were physically slowing down the electrical conduction in the heart, that delay would actually be visible on a standard ECG monitor.
The specific part of the ECG wave that represents the ventricles depolarizing is called the QRS complex, right? Usually it's a tight, narrow spike.
Exactly. But because the sodium channels are blocked, the wave takes longer to travel through the muscle tissue, which physically stretches the spike horizontally across the paper. They discovered that the width of the QRS complex was a far more accurate predictor of clinical danger than the actual concentration of the drug in the patient's blood.
Here's where it gets really interesting.
Yeah.
So you're saying a patient could have a normal-looking blood test, But if their QRS wave is wide, they could drop dead at any minute.
Yes, they assigned hard thresholds to a simple line on a monitor. If that QRS wave stretches past 100 milliseconds, the risk of violent convulsions skyrockets. And if the QRS duration stretches past 160 milliseconds, the patient has a 50% chance of developing a fatal ventricular arrhythmia.
Wow.
It allows a doctor to look at a screen for 2 seconds and instantly know if the patient's heart is about to stop.
But knowing the heart is about to stop doesn't really help unless you can fix it. And when you look at the therapeutic versus lethal dosing, the margin of error is just terrifying. A standard therapeutic dose of something like amitriptyline is maybe 150 to 300 milligrams a day.
Yeah, right. But ingesting just 1 to 2 grams can trigger that fatal cardiac blockade.
Think about how casually you pick up a 30-day supply of practically anything at the pharmacy today. Handing a severely depressed, potentially suicidal patient a 30-day supply of a TCA is literally handing them enough medication to kill themselves 3 times over.
Which is exactly what happened. Before the advent of safer SSRIs in the late 1980s, intentional self-poisoning with TCAs was one of the leading methods of completed suicide globally. The very tool meant to save their lives was the instrument of their death.
So when a patient crosses that 160 millisecond threshold, what is the antidote? I mean, we don't have a targeted monoclonal antibody or some complex molecular neutralizer for this.
No, we use something you probably have in your kitchen right now, sodium bicarbonate, intravenous baking soda.
Treating a complex psychiatric overdose with baking soda sounds absolutely absurd, but the chemistry is incredibly elegant.
It acts as a 2-pronged brute force physical assault on the TCA molecule. The first mechanism is alkalinization. By infusing sodium bicarbonate, you rapidly increase the patient's blood pH, making it more basic.
Why does changing the pH matter to a drug receptor?
Because it changes the ionization state of the TCA molecule. Drugs bind to receptors based on electrical charges. By shifting the environment to a higher pH, the TCA molecule becomes non-ionized, meaning it loses its electrical charge.
So it physically loses its magnetic grip on the sodium channel and falls off.
Exactly. And the second mechanism leverages the sodium part of the sodium bicarbonate. You are flooding the bloodstream with a massive concentration of sodium ions.
You create an overwhelming electrochemical gradient outside the heart cells.
Right. So even if some TCA molecules are still blocking the channels, the sheer osmotic pressure and mass action of billions of sodium ions just force their way through whatever channels are still open, violently restarting the heart's electrical rhythm.
It's an incredible triumph of basic cellular physiology over complex pharmacology. But it also explains why psychiatry practically abandoned TCAs the moment SSRIs like Prozac hit the market. I mean, if you don't have to worry about cardiac arrest, why would you ever prescribe a tricyclic?
And that assumption is actually the center of a massive ongoing debate in modern psychiatry today. It is true that SSRIs replaced TCAs almost overnight because of the overdose safety profile, but it was a revolution in safety, not a revolution in efficacy.
Are you saying the older, dirtier drugs actually work better?
Well, in many head-to-head clinical trials, TCAs perform just as well as modern SSRIs. More importantly, large meta-analyses suggest that for patients suffering from severe treatment-resistant melancholic depression, the profound physical slowing and absolute anhedonia we discussed earlier, TCAs, might actually be significantly more effective than SSRIs.
Because that dirty sledgehammer approach is jolting multiple neurotransmitter systems at once, rather than just gently tapping serotonin?
Exactly. Many clinical psychiatrists argue that our fear of the overdose risk is causing us to undertreat the most severely ill patients. They advocate for returning to TCAs for severe cases, but mitigating the danger by prescribing only small, sublethal quantities at a time.
Like maybe a 5-day supply.
Right, which also forces the patient to have more frequent clinical contact.
It forces us to ask if we threw the baby out with the bathwater. But even beyond depression, TCAs are far from obsolete, right? They've found a second life in modern medicine.
Absolutely. Because they interact with so many different neurological pathways, they are incredibly useful at low doses well below the cardiac danger zone. Amitriptyline and nortriptyline are prescribed daily by neurologists and pain specialists for chronic neuropathic pain, like diabetic neuropathy, and even as a prophylactic treatment to prevent migraines.
They basically act to dampen the hyperactive pain signals firing down the spinal cord. And what about pediatrics? I read that impramin is still used for children.
It is prescribed for pediatric nocturnal enuresis, which is severe bedwetting.
Using a potentially lethal 1950s psychiatric drug for bedwetting seems extreme. How did that even work?
It leverages the exact dirty side effect we criticized earlier. Remember the anticholinergic toxidrome?
The pathway that causes urinary retention by relaxing the bladder muscle and contracting the sphincter.
Yes. Pediatricians utilize that specific isolated side effect to physically prevent the child's bladder from emptying overnight.
That is wildly resourceful, using the accidental side effect of a failed antipsychotic to fix a plumbing issue.
If we connect this to the bigger picture of where pharmacology is headed today, we have to look at the newest generation of blockbusters, the SNRIs. Drugs like venlafaxine and duloxetine.
Serotonin, norepinephrine, reuptake inhibitors.
Right.
That is the exact mechanism of the original TCAs.
It is the exact same mechanism. After spending the 1980s and 90s perfectly isolating serotonin with the SSRIs, researchers realized that patients were actually missing out on the mood and energy benefits of boosting norepinephrine. So the pharmaceutical industry went back to the drawing board, looked at the original TCA dual action mechanism, and just used advanced molecular engineering to build a cleaner molecule.
Wow.
SNRIs block both transporters, but they don't crash into the histamine, acetylcholine, or cardiac sodium channels.
So what does this all mean? Let's recap for you listening. We started in a Swiss hospital in the 1950s with Roland Kuhn observing that a failed agitation-inducing antipsychotic miraculously woke up catatonic patients.
Yep.
We explored how that accidental discovery proved depression was a biological illness, birthing modern psychiatry.
And we mapped that clumsy, dirty chemical structure that acts like a master key, causing dry mouth, dizzy spells, and weight gain.
And we dove into the terrifying reality of cardiac sodium channel blockade and how an ER doctor uses the width of a line on an ECG monitor and a bag of baking soda to stop a fatal overdose.
The story of tricyclic antidepressants is the perfect encapsulation of pharmacology. It is messy, it is dangerous, it relies heavily on clinical accidents, and it requires a profound respect for the delicate electrical balance of the human body.
It leaves me with one final thought for you to mull over. We view medicine as a straight line of constant innovation. But if our most advanced, state-of-the-art treatments for depression today, the modern SNRIs are fundamentally just cleaner versions, trying to perfectly recreate the exact same dual reuptake mechanism of a 1950s laboratory accident, are we really inventing new cures for the human mind today? Or have we spent the last 70 years just trying to build a safer version of the very first accident? Think about that next time you look inside a medicine cabinet. Thanks for joining us on this deep dive.